Hello, everybody. Thank you for coming. My name's Laura Tam. I'm the interim dean at the Faculty of Dentistry. I'll begin by acknowledging this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work on this island, on this land. I would like to welcome all of the alumni and friends to our open house today. I feel very fortunate to be interim dean during this special 150th anniversary year. As you enjoy our open house today, you'll join us as we reflect on our accomplishments over the past 150 years, from groundbreaking inventions, improvements in patient experiences, to excellence in research. You'll also be invited to see where we are at today. I'm sure a lot has changed since many of you studied in this very building. We're continuing to make improvements, many of which you'll learn about and see for yourself today. Our grad programs consistently attract the best talent from professors to students. You're going to hear from these students shortly, who are studying and doing incredible research in each of the 10 specialty grad programs we offer. Their work is a testament to the depth and breadth of our education. We are the only dental school in Canada offering all 10 specialty programs. These programs are what make us one of the best dental schools in the world. In fact, I'm pleased to report that the Faculty of Dentistry has once again ranked as the top dental school in Canada and 24th in the world, according to the 2024 Shanghai rankings by subject. Our success is a shared achievement, and we attribute much of it to you, our alumni, and our supportive community. Which brings us to the future, the next 150 years and beyond. We already have some exciting things planned for the very near future. Thanks to a generous donation from the Rossi Foundation, we are progressing with planning for rebuilding Clinic 2 and hope to begin renovation soon. If you haven't already, today you'll have a chance to see the most recent renovation of our preclinical simulation lab, which opened this spring. This was a huge project made possible by generous donations of our community. The Rossi Clinic is an even bigger endeavor. This $40 million project will help us reimagine our building. The new Clinic 2 space will include a mix of 75 open and closed operatories with a modern design and equipment to mirror what students will experience after graduation in private practice. It's been a long time coming, and it's essential that we make these changes to this clinic and also to patient reception, which is the first point of entry for the public and their first impression of our faculty. We're grateful for each and every bit of support that we receive for these essential upgrades that will enhance both the student and the patient experience. If you're interested in supporting our building upgrades, please talk to Selena's team. There are many opportunities to name an operatory for yourself, your office, or even a family member. Now, in a nice tie-in to the future, I'm extremely pleased to pass the microphone and soon officially pass the torch to Professor Anil Kishen, who, in case you missed it, will be the faculty's new dean as of July 1st. Anil has been an appointed faculty member since 2009 and is currently serving as Associate Dean, Graduate Studies. He is a world-class innovator in the field of endodontics, teaching and conducting his own research in bioactive nanomaterials, phototherapeutics to fight oral infections and improve patient outcomes. And I also say, having worked with Anil for more than 15 years, he's just generally a wonderful person, personable, conscientious, incredibly intelligent. We are in for a great 5 years in our history under his leadership. Welcome and congratulations, Dr. Kishen.
Thank you, Dean Tam, for the very warm introduction. I'm truly honored and excited to be selected as the next dean of this remarkable school. At this time, I want to recognize Laura for her leadership over the past 3 years. Laura, thank you for all you have done and all you have continued to do for our school and our students. As I begin a new chapter from July 1st, I look forward to working with all of you as alumni, friends, collaborators, donors, faculty, staff, and students to ensure that the next 150 years of U of T Dentistry are well poised for continued success and leadership. As Associate Dean of Graduate Education, I have had the privilege to see firsthand the depth and breadth of clinical training and research being done by our graduate students. Today, I'm delighted to be able to facilitate what will be a wonderful showcase of talents from different clinical specialties. And I hope you enjoy hearing from this group of bright, curious, and ambitious U of T graduate students. So without further ado, I would like to introduce our first speakers, Dr. Bashir Haj Hamid and Dr. Kathy QC. As Bashir and Kathy is setting up the PowerPoint, I just want to share a few facts about them. The first thing is that they are from the specialty of prosthodontics. And an interesting fact about Bashir is that Bashir is a big fan of spin classes. So if you know any such classes in your neighborhood, please feel free to share with Bashir and he'll be happy to try it out. As far as Kathy is concerned, Kathy loves to play violin and is a member of the Summer Hill Orchestra here in Toronto. And if anyone loves classic music, they have a concert coming up on May 12th. And public is they're all welcome there. All right, over to Bashir and Kathy.
Thank you, Dr. Kishen. Thank you, Dr. Tam. So I am Bashir Haj Hamid, and this is Dr. Kathy Kusi, and we are in Grad Prosto. And today we're going to talk to you about building beautiful smiles, the prosthodontics pathway. So as a rate of partial and complete edentulosum, which means that the people who lose either single tooth or multiple teeth, it's up to 67% based on the global population, based on the recent studies. These tooth loss could reduce the oral quality health for these patients and also could cause cognitive impairments in their function and their aesthetic. There is always question in mind why you see a prosthodontist. Prosthodontist is a specialist of restorative and prosthetic dentistry, which aim to manage conditions associated with missing teeth or any deficient teeth. So the treatment goal for all prosthodontists is actually to restore and rehabilitate the oral function, comfort, and appearance for these patients. And the pathway of prosthodontists starts from diagnosis, treatment planning, moving to oral rehabilitations, following maintenance.
So we just wanted to take you through this journey. We always prefer to meet the patients at the beginning. So this is very similar, and a lot of people will make the analogy, prosthodontists are like the architect of the mouth. So some of you may have heard this analogy, but if anybody is surprised by this, we are the master planners in some situations. We focus on many things, which we'll all be familiar with: history, concerns, our exam, and we use many tools and records which help us to come up with a summary, problem list, and diagnosis, which will be individual and personalized to each patient, and determine a number of treatment options on how we can move forward to address their concerns. These tools and our workflows can be a mixture of analog or traditional conventional methods, or also digital methods. We're very proud at the University of Toronto that we have recently in the last few years under Dr. Gantz made lots of progress in the digital workflows with a number of scanners and other techniques. Ultimately, as Dr. Tam said at the beginning, we have also a lot of collaboration and interdisciplinary care. And at the U of T, that's a great opportunity to work with other specialties from all fields to come up with that comprehensive plan.
After we do the planning for these patients with the help of all other specialties, we actually can provide them with several options in terms of oral rehabilitations. Those options could come as a fixed prosthesis or fixed teeth, when we can actually give them either crown or bridges or implant restoration with the help with our oral surgery department and the perio department here. Or we can also give them some veneers to give them like more aesthetic considerations. On the other hand, also we can give them some removable prosthesis to give them oral function and also restore their aesthetics, which could be either partial dentures or could be complete dentures with the help to restore their occlusion.
Ultimately, at the end of the day, our aim is to take our patients from their beginning point, wherever that may be, and restore their dentition in order to bring back all of their smile and their personality. At the University of Toronto, we have many different research initiatives that are on the go in all of these aspects of treatment and care, which Besher has already highlighted. Fixed, removable clinical studies. We're doing a zirconia study on surveyed crowns right now, which is a previously unstudied area. So many interesting things that are on the go, trying to aim to improve the predictability and success of our patient outcomes. So thank you.
Thank you, Bashir and Kathy. So next presentation is from Diego Proano, and Diego is from the specialty of dental public health. The fun fact about Diego is that he is a great fan of soccer, and his fan team is Universitario from Peru. Did I get it correct?
Yes.
All right, good. Which literally means university student. And now you know why Diego is still a university student. All right, Saul, please.
Dental public health is fundamental to ensure we live in a fair society, as you will soon see. Wings symbolize freedom, liberty, our ability to go anywhere we want, whenever we want. In this world, all goods and services are little planets that float around in the sky. And to get there, you need to fly. For Oliver, a man, father of 2 kids with unstable employment, flying is risky. Oliver and others like him, they fear their wings will one day be too weak and too tired to stay afloat and fall into catastrophe, which few have recovered from. So one day, Oliver was having his breakfast and he felt he cracked a tooth. A cold, excruciating pain shivered his entire body. He shut his eyes and knew there was no way around it. He needed to fly to the dental planet, and with huge effort, he did. The dentist took care of him, treated his pain and restored his tooth, gave him his smile back. And smiling, Oliver flew away to the planet of groceries to get some food for his kids. As he was flying, his wings became too tired, and so he fell. His tooth was saved, but his wings were gone. Oliver's story might reflect an unfair trait of Canada's oral health care financing. And to see how true this is, we conducted an investigation to examine how many families fall into catastrophe just like Oliver, because they have to pay for healthcare out of their own pockets. And then we examined the contribution of oral healthcare. As food, rent, and utilities are essential in any household's life, we estimated the basic amount all households should have or should be spending on. And then we looked at the portion of payments on healthcare from the household's income after they've met these basic needs. When that portion was high, then the family was financially stumbling, experiencing catastrophe, just like Oliver. But some families could barely or couldn't even meet those basic needs and still spend on healthcare. Around 2 million people each year, on average, we found fell into catastrophe just like Oliver in Canada from 2010 to 2019. Oral healthcare was the second highest contributor to this catastrophe. And from every 10 cents spent on healthcare, too were spent on oral healthcare, which was higher among the low-income earners than the high-income earners. And thus, private health insurance did provide some financial protection. It did benefit more those high-income earners than the lower-income groups. However, if we build bridges, then the story is different. Weak wings are no longer fatal, and we did just that. In our second study, with the generous support of Green Shield Canada, we built a bridge to and out of the dental planet to provide comprehensive oral healthcare to those who were unable to fly to the dental planet. And then we examined what dental services would have led families to Oliver's catastrophic fate. We found that we need to provide coverage for endodontic treatments in order to prevent the risk of catastrophe. Our findings and methodologies, we hope, will help policymakers in monitoring the strength of the bridges that are built and what dental services need to be part of that bridge. By building strong bridges or strengthening the ones we have, we hope Oliver's story one day becomes an echo of a distant past and no longer a story of a present threat. To finalize, if wings symbolize economic freedom, then bridges symbolize unity. My dear audience, building a fair society is at the heart of dental public health. Thank you very much.
Thank you, Diego. The next presentation is from the specialty of endodontics, and we have two presenters here, Gavin Radell and Adam Tipperman. Gavin is from Nova Scotia and is an avid year-round surfer, and Adam at the same time has participated in zero-gravity research flight. So we have two people. One is a surfer, another one is an expert in zero-gravity flight stuck within the root canals. So over to you.
All right, so thank you for the introduction. So endodontics is truly the best field in dentistry, no matter what the other presenters try to tell you today. So every day patients come to our clinic in intense pain and often with a deep sense of fear of the procedure they're about to experience. And we get to send them home pain-free and with a far less ominous perception of what it means to have a root canal. In the graduate endodontics clinic, our residents provide this service for over 600 patients per year, while also collaborating with world-renowned researchers to advance scientific knowledge and drive innovation in our field. So at the heart of modern root canal therapy is our deeper understanding of the complex anatomy inside of our teeth. So micro-CT imaging is shown here in the bottom left, shows a high-resolution 3D map of exactly what we're up against. And that's helped us refine our tools and techniques to tackle these anatomical challenges and improve treatment outcomes. And we are very excited that a micro-CT scanner is now available at the Faculty of Dentistry, which will continue to drive endodontic research of the highest quality. So how on earth can we clean and disinfect these tiny bacteria-filled canals that are the source of pain and apical periodontitis? Well, advanced irrigation technologies like lasers and the GentleWave system can help improve our disinfection of these hard-to-reach spaces that we know that our files are not touching with our conventional treatments. So laser-assisted irrigation uses light energy in the axis cavity to create photoacoustic shock waves in canal irrigants, allowing it to penetrate deep into lateral canals and dentinal tubules. This dramatically enhances our disinfection without needing to remove more tooth structure. Residents in our clinic have access to the GentleWave system, which is shown in the top right, which creates a vortex of sound waves and a hydrodynamic cavitation cloud of fluids, which again allows us to effectively clean entire root canal systems in minimally prepared teeth. And this technology is so powerful that it has also helped our residents remove fractured instruments from the apical third of curved canals, again, without any additional removal of tooth structure. But despite our best efforts, some stubborn endodontic infections still persist after our conventional treatments. In these cases, we can turn to guided endodontic microsurgery. So using CBCT scans and 3D printed guides, we can precisely access and treat persisting apical periodontitis through conservative osteotomy and root resection that preserves bone, avoids vital structures, and accelerates recovery. So what was once a blind and very delicate procedure can now be digitally planned and conservatively executed by our residents with extremely high precision.
So this case that you see here demonstrates a targeted and precise method for conservative, modern endodontic microsurgery. And it's one of the greatest ways that we have to address a persistent apical disease. And persistent apical disease is hallmarked by persistent inflammation. And based on our modern theories, we know that this is less of a balance of just removing infection, but more so to deal with the types of cell populations and signals that we see within an apical lesion. So thanks to research from our faculty and at large, we are trying to focus more on these avenues in our research projects. So in my research project, I'm working on developing a material that targets that avenue specifically. So traditional materials that we would use after access and debridement of a large lesion would involve bone graft particulate or PRF. And while these are very good at maintaining space and allowing for some theories of guided regeneration, they don't really address what we know about the behavior of persistent inflammation within apical periodontitis. The material that I'm working on as well is in the form of a gel, which is injectable, making it less messy, less technique sensitive, and more efficient for placement within small lesions in difficult to access spaces. So this project really highlights the union of a material science and biological theory coming together to work with our new and most innovative, conservative microsurgical techniques to drive advances that we hope can improve outcomes in endodontic surgery. So thanks for listening. If you want to come by our clinic and see some of the cool tools that we use every day, we're open until 6 o'clock up on the second floor. Thanks for listening.
Thank you, Gavin and Adam. I may have to support the statement they just said that endodontics is the best specialty. All right, so the next presentation is from the specialty of oral pathology and oral medicine is by Marshall McPherson. The fun fact about Marshall is he's currently balancing his graduate studies with being a varsity athlete with U of T men's curling team. But Marshall, it's all yours.
All right, so I'm not going to try to refute that root canals and endodontics is the best specialty. I'll leave that up to everyone to decide for themselves. But what I'm going to try to convince you is that the world of oral pathology is also very interesting. So for oral medicine and oral pathology specialists, oral cancer is by far our bread and butter. And I'm going to try to convince you that it's very difficult to tell the difference between something that's cancer and something that isn't cancer. So I've gone ahead and labeled 4 photos for you all. 2 of them are white patches that are labeled low risk. These are white patches that have a very low chance of becoming oral cancer. The 2 on the right are labeled invasive, and they are already oral cancers that need to be sent to an oncologist for treatment. Visually, I hope I can convince everyone that this is very difficult to do. And so in the world of oral pathology and oral medicine, we rely heavily on biopsies. And don't worry, I'm not going to be talking too much about biopsies because most of the dentists here, their eyes already glazed over. But needless to say that even on biopsies, when we're looking at cells under the microscope, it can be very difficult to tell if something is invasive or something is not invasive. And these have huge repercussions for patients because a diagnosis of cancer means the patient will likely be going for surgery, may require radiation, may require chemotherapy. So we have to be sure about our diagnosis. But the reality is, in many cases, we aren't sure. Here at the Faculty of Dentistry, our program director, Dr. Marco Magalhaes, who has a lovely lab up on the 4th floor that I recommend everyone go visit, is working on a new diagnostic tool to help us in these cases where we aren't sure whether something is cancer or isn't. And it's called spatial transcriptomics. At the very basic level, what we're doing is identifying each individual cell on a slide. We're identifying the markers and the proteins that that cell is producing, and then we're assigning it a color. Not only is it very nice to look at and very pretty to look at, but the color map helps us see exactly what individual cells within the entire system are doing. And so we can see here, this is a biopsy of skin, and we can see that each level of skin has different colors associated with it. So each level of the skin is doing something different, despite the fact that they look the same when we're looking at it under the microscope. So where does this come in with oral cancer? As I was saying, in certain cases, it can be very difficult to tell the difference between oral cancer and not oral cancer. If we know certain markers that we have that are pathognomonic, that are hallmarks of oral cancer, we can send our slides into a spatial transcriptomics analysis. We can set a specific color to those markers and then just look for the colors on the map as opposed to look at the slide and see what we're looking for. So in this case, if we assume that certain markers are going to come up blue based on how we've set it up, those cells are going to be ones that are involved in the growth of the tumor. The ones that are more yellowish colored are going to be the ones that are involved in protecting the tumor from being detected by your immune system. If we know the markers of cancer, we can run this analysis and we can identify oral cancer faster than my eyes, either with the patient in front of me or under the microscope, can tell. It allows patients to have an earlier diagnosis and a more accurate diagnosis, much longer or much earlier before we can tell as pathologists. In cases of treatment planning, this also has huge implications moving forward. If we can see now that there's different types of cells in this cancer tumor, it explains why we don't have a 100% cure rate for cancer. Because right now our therapies are targeted at destroying all the cancer cells. But we're seeing that there are differences in the different cancer cells. Where this leads in the future is a potential where we have a sequenced therapy for different types of cancers. And it depends on what cells are in the tumor. And so in this case, we would target the yellow cells, the cells that are involved in masking the cancer tumor from your immune system first, get those out of the way, and then hit with a second, different type of chemotherapy to kill the rest of the cells. This has the ability to have a tailored and patient-specific approach to oral cancer treatment. And Dr. Magley's lab here on the 4th floor is one of the forefront labs in North America doing this type of work. We're hosting different researchers coming from as far as Brazil to do this type of work across different types of tumors, both cancer and non-cancer. And all of that is happening in the same 5-story building that we're all sitting in today. Thank you.
Thank you, Marshall. The next presenter is from the specialty of oral and maxillofacial radiology, and the presenters are Ryan Sang and Jared Crane. Fun fact about Ryan and Jared is that both of them share a common middle name, Elliot, but their spellings are different. Over to Jared and
All right, so good afternoon, everybody. I'm going to start the presentation by posing a question to the people in the audience. For the dental professionals here in the room, have you ever seen something on a radiograph or an image you weren't exactly sure what it is or what to do with it next? Well, us here at the Oral and Maxillofacial Radiology Department, we can help answer that question. And so my name is Jared. This is my co-resident Ryan. We're first-year residents within this program, and we're here to talk to you a little bit today about our department and some of the things that we do. So if you do send us some images and you're not sure what's on it, either two things are going to happen. We can send you a helpful report back, letting you know what's going on and potentially what the next steps would be. Or we could look at bringing the patient into our special procedures clinic, also affectionately referred to as specials. So what this clinic is, it's a collaboration between oral medicine and pathology, because as you know, University of Toronto is the only place in Canada with all 10 dental specialties under one roof. And we take full advantage of that. We have an oral medicine and pathology instructor as well as an oral radiology instructor overseeing us and helping us run the special procedures clinic. So when we bring a patient in, we do a full comprehensive medical examination followed by extraoral and intraoral exam. And then we assess to see what other imaging may be required. Could range from an intraoral, periapical image all the way up to a cone beam CT study. We then acquire those images, hopefully come up with a diagnosis, and then if any follow-up is required. So a unique thing about our specialist clinic is that we're actually able to do the follow-up here in our clinic. We'll bring the patient back in a year or whatever timeline may be required, and we will do a follow-up ourselves and send you back an updated report to keep you in the loop and tell you what's going on.
So our specialist procedure clinic offers a lot of services, some of which include but are not limited to salivary gland investigation. So sometimes if patients have a suspected salivary stone or they have a reduced salivary flow, then we're able to use a specialized technique in which was developed by U of T, in which we inject contrast through the salivary duct, and we're able to use cone beam CT to image the gland, as you can see in this picture on the left. We also do temporomandibular joint assessment. So we all know in private practice, TMJ symptoms are quite common now. So with the use of cone beam CT, we're able to see osseous structures very clearly and notice very subtle changes in the TMJ joint. We also do investigation of pathologic lesions, which I'm going to talk to you about in the next case. So this was a panoramic taken by a general dentist on June 2019. And you can see that there in the left mandible of the patient by the 3-7, there's a lesion there. 5 years later, they took another panoramic image and you can see there's been noticeable changes. So very wisely, the GP thought this warranted further investigation and they referred the patient to the specialist clinic. So we actually saw this patient twice in special, so in May 2024, and then we also did a follow-up in March 2025. And after doing an extraoral and intraoral examination and medical history exam, we ended up taking cone beam CTs at both appointments. So here you can see sagittal slices of the cone beam CT. And what's important to note is that no treatment was done, but you can see that on the right with the arrows, there's been bone infill into the lesion. Again, we have axial slices of the cone beam CT. And again, between the two dates, you can see that there has been bone infill without any kind of intervention. So this was diagnosed as a periapical cemento osseous dysplasia with simple bone cysts. So the long name isn't important to remember today, but what's important to know is that this is a benign lesion and does not require treatment. So by getting to the right diagnosis, we were able to prevent the patient from getting a very invasive surgical procedure or biopsy. This just shows the importance of longitudinal follow-up, advanced imaging, as well as getting to the correct diagnosis in order to provide the right treatment for the patient. So there are many benefits of special procedures clinic for the patients. A lot of times having an unknown diagnosis can be a source of stress. So in collaboration with oral medicine and pathology, we're able to produce a definitive or differential diagnosis, which can help the patient feel more relaxed. Patient education is always at the forefront for us, and we take great care in educating patients about the nature of their condition, as well as what to expect in the next steps.
And for the students, obviously, our main benefit is improved education. We get to be involved in the process from the start to the finish. We get to prescribe, and we get to also acquire any additional imaging that may be required. Provides us with a great overall learning approach, as well as we also get that expertise of the oral medicine and pathology instructor to provide any additional insight to soft tissue lesions and just get that different perspective on things. And then for the faculty, in addition to the above benefits, we also get to add to our case database. And this case database is then used to educate both undergraduate and graduate students alike, as well as it can act as a reservoir where graduate students can take cases and take data from to help with their master's projects. And if any of you have been up to our clinic on the second floor already, you'll see that there are some research posters on the walls. And those posters are done by previous graduate students or current graduate students as well, actually. And most of them have taken data from this case database. So thank you for listening to us today. If you haven't been to our clinic yet, we encourage you to come up and visit, take a look at the posters on the wall and see what we have going on there. And we look forward to working with you in the near future. Thank you.
How are you all doing? Doing well? All right. So the next specialty presentation is from oral and maxillofacial surgery. and it's presented by Freddie Mystery. The fun fact of Freddie is that Freddie loves long bike rides and even longer discussion on geopolitics. Right time to talk about it. Just don't ask him to choose between a new gear set and a new book on foreign policy. So that's a disclaimer. All right, Freddie.
Thank you so much for the introduction, Dr. Kishen, and thank you everyone for being present over here on this lovely afternoon on a Saturday. So my name is Freddie Mystery, and I'm the second year postgraduate resident in oral and maxillofacial surgery. So for those of you who don't know, oral and maxillofacial surgery program was one of the first program which had started in University of Toronto way back in 1945. So this year we are celebrating almost our 80th year. And within the past 80 years, we were led by 8 program directors. And the most recent one, we are led by Dr. Caminiti right now. So my presentation will be highlighting, since this past 80 years, what all things we have achieved in the realm of oral and maxillofacial surgery, and what all we have been keep on striving for excellence more and more. So for those of you who don't know, currently the oral maxillofacial surgery program is 6 years, but starting next year, it's going to be a 6-year program. And pretty much after the presentation, you will understand why it needs 6 years for the training. So I will just be highlighting 2 cases, and please pardon me for the graphics of this presentation. So as you all know, these 2 cases are quite complicated and not the usual case which you will be seeing in your dental clinic. Or even if you see, you will be definitely referring them to us. So the first case is a very fine gentleman with 2 kids who came up with unfortunate having this big pathology. And as you all know, this is like one of the pathology which we call in our terms, after the help of our oral pathology colleagues, when we take a biopsy and then they give us a report, it turned out to be an ameloblastoma. Well, it's not like a new disease or anything. This disease has been present since a very long time, but the approach to the disease has been changed quite drastically. Though we are striving with all the other colleagues to come across a treatment where we can do a minimally invasive treatment, but unfortunately, still in 21st century, we need to do quite graphic surgery where we need to resect quite a large amount of their normal anatomy. But the point over here is this we have been doing since quite a long time. And now the times are changing, and we no longer focus on just resecting these jaws and leaving them high and dry. But the idea is to reconstruct them at the same surgery so that they don't have to go for any further surgeries. So along with the help of our colleagues from other specialty like plastic surgeries, head and neck onco surgeries, as well as our dental colleagues like prosthodontists and radiologists, we do an in-depth planning of these cases, and we try to give them the teeth at the same surgery itself. So when they walk out of the operating room, they are having the teeth on the same very day, which is quite phenomenal if you see in today's day and time. The next case, well, if you want to know more about him, I would suggest you YouTube temporomandibular joint reconstruction syngnathy on YouTube, and you will see a lovely video by our program director who has highlighted this case, and it was covered extensively by the media as well, by CP24 and CTV. So this case, what we call in our realm is a case of hemifacial microsomia, which the patient had undergone surgery at quite a young age, but had quite a lot of complications. And it's not because of the surgeons were at fault when doing the surgery, but it's just the techniques and the resources which were available in that country where the surgery was done. Unfortunately, the patient developed further complications of ankylosis on the left side. And along with that, if you focus, not only his hard tissue or the bones were fused, but also his soft tissues were fused together as well. And if you see, like along with our help of radiologic colleagues, we got all the 3-dimensional scans for these cases. And if you focus on the picture on the right-hand corner of here, this is a full virtual surgical planning for these cases with regards to having a total joint replacement. We are very fortunate at U of T over here. We have our own 3D planning lab in our specialty over here in our department. So please come by after the lecture and have a look into our 3D planning lab where we do most of our planning in-house, where the residents plan the cases along with the staff. And we also plan and print out 3-dimensional splints at the same time before the surgery. So we took him to the OR. We replaced him with those biomechanics joints. And along with that, we also had to do a corrective jaw surgery where we had to place his jaw in a correct position. This was definitely a life-changing surgery for this patient. Imagine if you're not able to open the mouth and talk normally from the time over there till the time where you can open your mouth, eat well, talk well, and smile well, and lead a happy life. Well, thank you so much for giving the opportunity to present over here. And I wish that you guys please come to the department and have a walk down the memory lane. It's pretty much the same. You will be remembering all your days over there. Thank you.
Thank you, Freddie. So the next specialty is orthodontics, and the presenter is Farhad Sabuti. Farhad was a member of the youth national swimming team of Iran for 7 years, and he has won 40 medals in various national and international competitions. He also has a passion towards music, and he plays 2 traditional Persian string instruments. So now you know why he chose orthodontics as a specialty.
Hello, everyone. Thank you so much for introduction, Dr. Kishen. Good afternoon, ladies and gentlemen. Actually, it's a real honor for me to welcome you all to this fantastic open house for the 150th anniversary of Dental School at University of Toronto. My name is Farhad Sabuti. I'm the SATP resident, 1-year equivalency program for the specialties at University of Toronto Orthodontic Grad Clinic. Before I start my presentation to showcase 2 different cases with 2 different severe malocclusions, to show the orthodontic abilities and what's being done at Grad Ortho Clinic in 3rd floor, I want to take a moment to introduce our grad program. The first graduate orthodontic department in Canada, established in 1945, same to surgical department, Dr. Actually Freddie mentioned, but we are also the first one, 1945. And also one of the oldest grad ortho program in North America. Our program takes a comprehensive approach to orthodontics, which goes beyond teeth alignment and includes treatments for dental and skeletal abnormalities, but utilizing different treatment protocols, growth modification, camouflage strategies, and surgical orthodontics intervention modalities. Our program is being led by Professor Sanjay Suri, who is program chair at this moment. I will showcase 2 cases which demonstrate the range of orthodontic treatment offered at the University of Toronto, which show a great amount of favorable transformative changes for our patients' smile. The first case is skeletal class 2 malocclusion treated with twin block appliance supervised by Professor Pavel Sektakov. Thank you so much, Dr. Sektakov, for your attendance. He's leading interceptive orthodontic clinic on Fridays morning, and also he's running our Monday afternoon clinic as well. And the second case is skeletal class 3 malocclusion. Pardon my French, doctor community. The patient actually refused to go under any surgical intervention, so we decided to camouflage this case with uncommon extraction pattern. 13-year-old boy presented at Grad Ortho Clinic in September 2022, and his chief complaint was retrognathic mandible, procline and protruded upper front teeth, and history of trauma twice to the upper centrals. As you can see, based on facial findings, he had convex profile, retrognathic facial type, and short lower anterior facial height. Intraoral wise, patient had class 2 division 1 malocclusion, increased overjet, 100% overbite, impinging deep bite, and class 2 unbuccal segment and diastema between upper centrals. The treatment plan actually was done for this case was two-phase orthodontic intervention. Phase one was growth modification to change his growth pattern and bring mandible forward and restrict actually or restrain the maxillary growth. This phase one treatment was done by functional appliance. As you know, we have two types of functional appliance, either removable or fixed functional appliances. We decided to start phase one with the removable appliance, functional appliance called twin block. These appliances actually accelerate mandibular growth and try to bring mandibular dentition forward and bringing the maxillary dentition backward. As you can see, after 1 year of phase one, we corrected the skeletal discrepancy. So, and after that, immediately in phase two, we decided to treat this case with fixed orthodontic appliances. The treatment actually overall took 2.5 years, phase one, 1 year, and 1.5 years for phase two. As you can see, stable posterior class one occlusion, both sides, midlines are coincident, and ideal overjet, ideal overbite, and also enhanced profile. It's very balanced facial actually profile. The chin prominence is very good in profile view. And after that, usually at Grad Ortho Clinic, for all our patients, we bond lower and upper fixed lingual retainer. On top of them, usually we use removable retainer, either Holly retainer or a 6 retainer based on the case actually needs. The second case I'm going to show is for 15-year-old female case referred by her dentist to Grad Ortho Clinic. Actually, at Grad Ortho Clinic on Wednesday afternoon, we have surgical orthodontic clinic. That's a great collaboration between orthodontic department and surgical department. And we are doing both camouflage treatment and surgical orthodontics on Wednesday afternoon clinic. She presented there, and the main treatment plan, the ideal treatment plan presented to her and her family was orthognathic surgery, doing jaw surgery to correct this huge skeletal discrepancy. In March 2022, we started the treatment. As you can see in her clinical photo, long lower anterior face height and chin deviation to the left, and also malar deficiency or paranasal deficiency, and severe skeletal class 3 was actually quite apparent intraorally. The case was class 3, upper incisor were severely proclined, lower incisor were retroclined, and lower midline was shifted to the left by 4 millimeter. Unfortunately, patient actually refused to go under any surgical intervention, so the supervising team decided to treat her by camouflage treatment and doing extraction treatment. So we took 4 teeth out. One of them was tooth number 25, which was impacted. And we took 1.7 out to provide a spare for 1.5 after digitalizing 1.6. And on the bottom, you can see the severe crowding. So the supervising team decided to extract 3, 4, and 4.2 to do substitution treatment plan for this case. After 2.5 years, that was a very tough camouflage case. You can see the result. Pretty stable posterior occlusion, class 1 canine. Upper midline is coincident with the face. We tried to hide skeletal discrepancy to the left by bringing the dental midline to the center line. And also, patient now is wearing upper and lower fixed retainer, on top of them removable retainers. These photos were taken by me 2 months ago. Patient is quite stable and satisfied with result. So a range of treatment protocol and strategy actually is being done at Grad Orthodontic Clinic nowadays. So it could be interceptive growth modification treatment, it could be interdisciplinary adult treatment, and many camouflage cases are getting treated at our clinic. Thank you so much for your attendance, and thank you so much for this.
Thank you, Farad. So the next specialty is pediatric dentistry, and the presenter is Hetal Desai. Hetal is an avid Harry Potter fan, and I was told she's yet to outgrow Legos and jigsaws. And now you know why she joined pediatric dentistry. Over to you.
Thank you. Thank you, Dr. Kishen, for the introduction. So I'm Hetal. I'm one of the pediatric dentistry residents. I had a proper introduction prepared for pediatric dentistry, but I'm going to take the bait of endodontics being one of the best specialties. And I'm going to say that probably in endodontics, you're looking at one, maybe a couple other teeth. In pediatrics, we're essentially looking at the patient as a whole. And oftentimes, we are the first providers to pick up subtle signs of conditions that may not be diagnosed in a patient. And we're the first people to sort of diagnose the condition. And this talk is essentially a talk that highlights that aspect of my work. So this is a case where we saw a 16-month-old male patient who came into the ED at Sick Kids. There was no known medical history for him. The family history was non-contributory as well. The chief complaint at the time was persistent bleeding, upwards of 12 hours. What essentially had happened is that the child had fallen 6 days before he presented to the ED. He had sustained an injury to his upper lip and frenum. And at the time, the parents had a hard time controlling the bleed, which is why he was taken to the local hospital, where some blood work was completed, which was found to be within normal limits. Tranexamic acid was used to control the bleed. And then the parents were, the family was discharged. It was recommended that the child follow up with a community dentist just to make sure that there was no additional trauma to the teeth. He was taken to the community dentist, wherein a labial frenectomy was recommended. The rationale was to facilitate healing in the region. The frenectomy was done using a laser, and at the time, the procedure was uneventful. But then the child began to bleed again 12 hours later, at which point he was asked to present to the Sick Kids ED. What we saw at the ED was that the child had a hematoma on his arm, and the site of hematoma was the same site where the tourniquet was tied a week ago for the blood draw. Intraorally, there was a lacerated frenum, which was the site of the bleed. And then when we looked at the blood work that was done at the other hospital, we did not see results for the PTT and von Willebrands, which is why we redid the blood work. And what we found was that the PTT was prolonged. We looked at the factor VIII levels, which were very low, and therefore a diagnosis of severe hemophilia A was made. The child was treated with a transfusion of the factors, and then the PTT had improved substantially thereafter. So what makes this case interesting is essentially the age of diagnosis, because typically in the United States, the age of diagnosis of severe hemophilia is about a month. The child was 16 months. This was one of the rarer cases, because typically we do pick up cases of bleeding disorders, but the severity is mild to moderate. Very rare for us to pick up a severe hemophilia case. And then there was no family history that was known at the time, but the mom was found to be a carrier thereafter. So endodontics versus pediatrics, I don't know, teeth versus health. You decide.
Thank you, Hetal. The last presenter is from Specialty of Anesthesia and is Saeed Tahir. Saeed, growing up, always dreamt of being a chef, but somewhere along the way, he traded the apron for a seat at the table and hasn't looked back. Although he still has a passion for cooking, he knows his limit and is happy to leave some dishes to the experts. Over to you, Saeed.
So I guess they were saving the best resident for last. So thank you, Dr. Kishen. So I'd like to thank everyone for being here today and joining us and celebrating this momentous occasion. Instead of giving you guys a case presentation, something that would probably bore you, I want to talk about something that I think is relevant to each and every one of us here today. So this short presentation was actually developed from one of our weekly seminars where we critically analyze novel updates in medical literature. So I want to start by just talking about some recent statistics that was published by the Heart and Stroke Foundation of Canada. So about 60,000 cardiac arrests occur outside of hospitals each year in Canada. That's roughly 1 every 9 minutes. A major subset of these cardiac arrests present in ventricular fibrillation or pulseless ventricular tachycardia. These are shockable rhythms and represent the most treatable causes of out-of-hospital cardiac arrest. And for these cases, delivering a defibrillating shock as early as possible is absolutely paramount. And for every minute that passes without defibrillation, a patient's chance of survival drops by 7 to 10%. Sadly, as of right now, only 1 in 10 people survive an out-of-hospital cardiac arrest. Quick bystander CPR and the use of an automated external defibrillator can double or even triple a patient's chance of survival. Now, it's well established that early defibrillation is critical in improving outcomes for patient survivability, most of us are familiar with that. But what hasn't really been talked about, well, at least not until recently, is the actual positioning of those defibrillator patterns. So historically, in the adult, the anterior lateral position has been the go-to choice for defibrillation. It's easy. There's no need to move the patient, minimizes interruption to the CPR. And current guidelines actually say that this position and the alternate, which is the anterior posterior, are actually equally effective. But the anterior lateral, which is seen here on the left side of the screen, has been the most familiar one and the one most often taught to us in our CPR, BLS, and ACLS courses. New evidence, however, that actually just came out in 2024, so just a few months back, suggests that this anterior posterior placement, so the front and back, actually has significantly improved outcome. So it was found that in out-of-hospital cardiac arrest, the anterior posterior placement can actually result in 2.5 times more likelihood of getting return of spontaneous circulation, which is getting your heart beating again, which I can all, think we can all agree that's probably a critical step in cardiac arrest. And this, although this is a new study that's come out, this could have a huge impact on future studies to help reshape our new guidelines. And it just serves that, a small improvement in these small steps can have huge impacts and save patient lives. It's a prime example of why we need to stay up to date with our literature and why we need to update our practices when new data emerges that, tells us to do otherwise. So even long-standing techniques like defibrillator pad placement can be refined by evidence-based improvements. Now, you must be wondering why I'm talking about heart attacks for this. The reason why is in our residency, we spend a significant amount of time talking about these potentially life-saving topics, and staying current with the latest evidence is a key part of our training. However, staying up to date on these critical interventions isn't just academic, but it's part of our responsibility to patients. Dental anesthesiology residents train extensively in managing medical emergencies. We are trained not only to be experts in sedation and anesthesia, but experts in crisis management as well. We are the ones ensuring patient safety during procedures, and oftentimes we are the ones teaching CPR and medical emergency response in dental settings. So I'm very proud that our specialty emphasizes emergency preparedness, and by staying informed and practicing drills, we help make our communities and clinics a safer place. Thank you.